of 2020 and decriminalized possession of small amounts of substance so that people could be steered toward treatment rather than the criminal justice system. We have three great people here today. Ron Williams is here from the Measure 110 Oversight and Accountability Council. He's traveled all the way from Portland to be with us today. He is a seasoned community organizer and has worked on and led multiple winning grassroots campaigns to increase access to affordable housing, prevailing wage jobs, pre-apprenticeships for minorities and formerly incarcerated persons, health care, green jobs, health equity, and economic inequality. Ron holds a Bachelor of Science in Political Science from Portland State University. He lives in Portland with his sweet shared dog, Roxy. His favorite thing to do when he isn't working is to take long trips with his son, Elo. I'll also mention our other presenters here. We have Rick Treleaven, who's the CEO of Best Care Treatment Services. And then he's also brought along Kristina VanAlstine, who is also with Best Care Treatment Services. She's the peer supervisor and housing coordinator. And so she will really provide us a lot of the on-the-ground perspective of implementing Measure 110 that really started being implemented in the winter and spring of 2021. So I'll welcome Ron first, and if anyone needs to mute the microphone, be sure to turn it to the off button right here so that if you're moving it up or down, there's not a lot of noise on video.
Stand close to the mic. Stand close to the mic.
Good morning, can everybody hear me okay? Oh, that's the exact thing you said to do, right? So, good morning, everybody. My name is Ron Williams. I'm the, Karen mentioned that I'm a member of the Oversight and Accountability Council, but I'm here today as the Director of Outreach for the Health Justice Recovery Alliance. The Health Justice Recovery Alliance is its sole function and sole purpose. It was founded in November of 2020 with the sole purpose of implementing or advocating for full, meaningful, and timely implementation about Measure 110. That's its sole focus. That's what it does. That's what we do. So I'm the Director of Outreach. We have an Executive Director. We have a communications person, a government relations person, a community organizer who does a lot of the building capacity around advocacy, and then we have a technical assistance person, someone whose sole purpose is to work with grantees who are really just having the experience of having to interact with the government bureaucracy for the first time in terms of paperwork and reporting and budgets and that sort of thing. So we have a full-time technical assistance person that works on that. Like I said, I'm the Director of Outreach. I'm also a person in long-term recovery, which I define as being alcohol and drug-free for almost 24 years now. And 24 years ago, I was homeless, jobless, penniless, living on the streets in Portland, thinking that my life was going to be pretty much devastation and ruin. And then in 1999, I found recovery. I was able to get some mentoring and support from someone who had traveled this path before. I was able to access quality, supported recovery housing, and the combination of the recovery housing, my personal commitment to a 12-step fellowship, and mentoring is the difference in my life. I never went to treatment, and so the community resources were the things that are different for me, and that's why Measure 110 is so important to me, because it actually mirrors kind of my experience of community supports. So now I'm going to walk through. So what I'm here to do today is just give an overview or an update about Measure 110 and let folks know where things stand. I just told you who I am. This represents kind of a coalition of organizations that were supportive about Measure 110 when it was proposed, folks who continue to be involved with the organization as our coalition. We have a coalition of over 75 organizations And this doesn't include the organizations that are providers who meet regularly with us on a weekly basis to provide information, expertise, advice, and guidance to us regarding our implementation, which we call the Implementation Alliance meeting that we have on a weekly basis. And I think Rob actually has been attending that meeting. So this is, and so just to give an overview or a background, ballot measure 110 decriminalizes, it does not legalize drugs, it decriminalizes small personal use amounts of drugs. It invests hundreds of millions of dollars in addiction recovery services and harm reduction services. Those are the two primary functions. Essentially, it also establishes the Oversight and Accountability Council which is made up of people with lived experience, people who are alcohol and drug counselors, people who are providers, people who work for CCOs, addiction medicine doctors, and folks like that are making decisions regarding granting the hundreds of millions of dollars in funding that comes from cannabis revenues that was a part of ballot measure 110. So Oversight and Accountability Council is made up primarily of people with lived experience, and it's a very diverse and quality council. Fundamentally, the law just treats people who use substances with a healthcare approach as opposed to moving people away from the criminal justice system. The services that are included in ballot measure 110 are low barrier treatment, which include detox, sobering, outpatient, peer supported services, peer mentoring, peer support, harm reduction services. The expansion of harm reduction is probably the biggest gift one of the biggest gifts of ballot measure 110. I don't know if you read the New York Times today, but there was even in Texas, they are embracing harm reduction as a strategy to reduce overdose deaths and improve the quality of life for people who use drugs. The Biden administration has also begun to relax rules and create a better environment for harm reduction to flourish. And supportive housing such as permanent housing, supportive housing, recovery housing, transitional housing, emergency housing, permanent housing, family housing are all able to be funded with Measure 110 funds. This gives you a look at the actual amounts that are involved in the ballot measure 110 decriminalization. So you can see there are felony amounts of possession, there's misdemeanor amounts of possession, and then there's an E-class violation. So less than 1 gram of this or less 2 grams of that results in a E-class violation. That's what my ballot measure 110 does. It creates this E-class violation, which is the equivalent of someone getting a traffic ticket. In addition to getting a ticket, police are required when they issue the citation to inform people about the way to get a screening for addiction recovery services through a telephone hotline. They're required to do that. And this just shows you what those amounts are. And those are very small amounts. Some people, other folks who are wanting to do decrim around the world and around the country think that these amounts are way too small. Local or recent research has shown the two major areas of to focus on, two major areas of focus that the research is showing really great benefit is in the area of decreased possession of controlled substance arrest and the infusion of funding for harm reduction. There hasn't been this level of investment in harm reduction ever, and so that's a huge thing. And this slide represents kind of what we're seeing in terms of the reduction in PCS arrests, or possession of controlled substances arrests, for those amounts. And the thing to keep in mind when we talk about personal use amounts, we're talking about what people think will get them through the day or the week and that sort of thing. And so these are people, and so the fundamental premise of decriminalization is that criminalizing people for a health issue only does a couple things. It destroys their ability to get jobs, it gives them a record for life, it blocks housing, student loans, and creates all these barriers, and it doesn't help them towards the path to recovery. And so the fundamental idea behind ballot measure 110, once again, is to create a health-based approach as opposed to a criminal system approach. And this just demonstrates how the decrease in arrests. Now this slide is kind of a little bit out of order, so I'm gonna go with this slide and just kind of talk to the outline a bit. Voters approved ballot measure 110 in 2020. It went into effect in February of 2021. They sat the Oversight and Accountability Council. The hotline came online in February 2021. In June, the legislature passed Senate Bill 755 that created clarity and added detail and addressed some of the silences of ballot measure 110. And they also awarded $31 million in access to care grants that allowed the Oversight and Accountability Council to make initial grants all over the state in early 2021. So there's two funding paths for ballot measure 110. One is access to care grants, and the other are behavioral health resource network, or the establishment of behavioral health resource networks that you're going to hear a lot more about as we go on. So the council continued working through 2021. In September, they established a set of rules for how the behavioral health resource networks would be established. They then moved towards creating an application process for providers to apply for funding for behavioral health resource network funding. That happened in the early part of 2022. The council began making decisions about awarding funds to behavioral health resource networks, or BERNs as we call them. In March of 2022, that process ended basically in August of 2022, where the approval of the BERNs were finalized, and funds started going out in September of 2022. And Rick and Kristina will be able to tell you much more about that. What I'll say about the $302 million that was appropriated by the legislature was that, if you can see here, it's broken down into the initial $31 million that included $11 million. Well, there's $31 million, and that's this slide over here. Access to care grants over here. That was the $31 million that initially went out. And those are the services that are provided with the access to care grant. And that left $265 million for the behavioral health resource networks. And that was what the council worked on and got funding out in September of 22. So the funding, the $39 million went to serve over 42,000 people. In the first 6 months, funding served 16,000 people, but by September 22, that initial 39, I say 31 to 39 million because there's some details, some inside baseball I'm not going to get into, but over 42,000 people were served with Measure 110 services. And then once the Behavioral Health Resource Network funding went out in from June to December of 2023, there's a period of time under which there's a grant period. So there's a grant period from July to September for the access to care grants, and then from June to December of 2023, that is the funding cycle, the first funding cycle for the behavioral health resource networks, and that was $265 million. That went to 160 organizations in the form of 233 contracts to establish 42 distinct behavioral health resource networks, at least one in every single county. And as of December of 2022, over almost 18,000 people have received services as a result of that. The next phase, which is where the Oversight and Accountability Council and the Oregon Health Authority have already decided to do grant extensions for all of the organizations who meet the criteria for continuing to provide services, which they want to continue services. They are in compliance in terms of performance data, financial data, and all of their compliance reporting is in order, then all those organizations, and I think 99% of the organizations who receive funding have requested to receive an extension, then moving forward from the January 24 to June of 25 will be the next funding period. And one of the things to note about that is that the cannabis revenues are down from, according to the economic forecast, and instead of having what initially was thought to be around $200 million for the council to make extension grants, there's only going to be about 150. The Health Justice Recovery Alliance is working and advocating for the legislature or to make that money up in the with the general fund. And this just goes over and shows more detail about the types of services that were received, the number of people who engaged in services, the number of people who received peer support, number of folks who received or requested housing, number of people who received treatment. And that's from the Access to Care grant, that initial $39 million that was appropriated by the legislature in 2021 in Senate Bill 755. So we're continuing, the Health Justice Recovery Alliance is continuing to do advocacy days in the legislature. This is a photograph of many organizations from Washington County, Clackamas County, and Multnomah County coming together to meet with legislators to talk about the programs and services that they are providing in their specific counties and in those specific districts. These are peers and harm reduction specialists and folks who provide housing, outpatient, meeting with legislators. The local networks is really what it's all about. The behavioral health resource networks are really organizations that come together. They're required to sign a memorandum of understanding to say how each organization, how each behavioral health resource network is going to provide, how they're going to coordinate, collaborate, refer, and ensure that anyone in the county, in that particular county, in that particular burn region, is able to receive Measure 110 services at the time that they need it at no cost. And this just goes on and talks more about the actual services. And this really kind of breaks down and shows what is the suite of services about a Measure 110. Intervention in the form of outreach and screening, sobering and detox, low barrier treatment, which includes outpatient housing. Residential is included. Residential treatment is one of the components only if the person is categorically ineligible for Medicaid or is uninsured or underinsured. And then there's also medicated assisted treatment, which is a big component. And so where things stand, I feel like I've been talking a really long time. So where things stand, and these are just more, I'm just kind of walking through, these are like news media reports of folks who have taken up the services, or folks of services being expanded in Eastern Oregon and Jackson County news reports. And then finally, it's just where we're at is that the voters passed a law, the legislature got on board with making sure that the services got launched. The Oversight and Accountability Council, working with the Oregon Health Authority, got funding out twice. They got the $30 million out, then they got the $265 million out. All those organizations have been funded. There are behavioral health resource networks in every county. There's the one here that you're gonna hear about. The one here you're gonna hear about has 7 organizations, and Deschutes County received over $11 million to provide these services. And so organizations are working together to ensure that all of the services in ballot measure 110 are delivered and are effective. The last thing I want to mention is there's been a lot of media, a lot of attention to ballot measure 110. And one of the last thing I want to mention is during this legislative session, there were, I think, 3 bills to repeal ballot measure 110. There were two bills that would have taken 50% of the funding away from ballot measure 110 and allocated it to either state police or to an economic equity investment fund. All of that stuff has kind of died or is not moving, and we're happy about that. There is a bill that I want to point out that had a hearing yesterday in the Senate Health Committee, which is a House Bill 2513, which was the legislature, particularly Representative Rob Knowles, brought together a Measure 110 work group to make improvements to ballot Measure 110 and Senate Bill 755 to kind of address a lot of the concerns that people had about it. And and so that bill, which went before the House about 2 weeks ago, was voted. There was a vote to improve ballot measure 110, and when the vote took place, all but 3 members of the House voted in favor of it. So that's bipartisan support, full bipartisan support that shows that ballot measure 110 is valuable and meaningful and should be supported, and so that's a key thing. The last thing I want to mention is in that bill, there's been a lot of discussion about what is recovery, what is treatment, what is the result of treatment, and in that bill, what they do is they actually define treatment using the SAMHSA, the Substance Abuse and Mental Health Services Administration definition of recovery, which is recovery is the process of change in which people improve their health and wellness, live a self-directed life, and strive to meet their full potential. That's all I have. Yes.
I have a quick question. Can you define what you mean by harm reduction?
Yeah, sure, I can. So harm reduction is a set of intervention and tools designed to improve the quality of a person's life while they are continuing to use drugs. For example, needle exchange, giving safe syringes, wound care, naloxone, which are an overdose reverse medication, making that's available over the counter. That's one of the things that the Biden administration made possible, is that naloxone is now available over the counter. You can actually get a naloxone, which is an overdose reversing medication, pretty much in any organization that provides harm reduction services, and most addiction recovery providers have access to it, and you can get it.
Question?
Yes.
Prior to Measure 110, people were, my understanding is some people were arrested and even incarcerated with felonies on their records for the small dosages that 110 now protects.
Mm-hmm.
Is there anything being done for those prior incarcerated and people with felony on their records to expunge the records? Anything to help recognize that today it's not legal? I mean,
Yeah,
yes, it's
there
legal
are
to do something, and they were arrested for things that today are legal, but back then they weren't.
Yes, there are bills that were introduced in the 21 legislature, the 22, and now the 23 legislative session. There have been bills introduced that actually do exactly what you're talking about: automatic and free retroactive expungement. I'm not sure, I haven't been really tracking that side of it because I've been tracking this side of it, but I can let you know kind of what the status of that is. But it is something under serious consideration. The ACLU, the Oregon Criminal Defense Lawyers Association, and many other organizations, Partnership for Safety and Justice, and many others are working on that very thing, and it's something that we expect to see some progress with.
Okay.
All right, thank you very much.
But I'll just wing it. Or do you know how to?
I don't, do you know where his PowerPoint?
Let me get Jonathan.
Okay. I'll just get started with the introduction while that happens. My name is Rick Treleaven. I'm the Executive Director of Best Care Treatment Services. Best Care provides behavioral health services in Jefferson, Crook, Deschutes, and Klamath counties. I'm the Community Mental Health Director in Crook and Jefferson County. we're the largest substance use disorder treatment provider in the region by a long shot. We have 3 residential treatment programs. We provide the only Latino residential program in the state. We provide intensive outpatient services for both substance use and mental health services in Crook, Jefferson, and Deschutes County. We also provide mental health respite services, and we have Burns, behavioral health resource networks in Crook, Jefferson, and Deschutes County. So we're deeply involved with this. I'm a licensed clinical social worker by training, and what maybe not a lot of people know is I'm also in long-term recovery. Been clean and sober for 42 years, keep coming back, it gets better. It's an inside joke, so. This whole Measure 110 piece made me reflect. My clean date is November 1st, 1980, which I had to look it up. It was 4 days before Ronald Reagan was elected president. It wasn't related, but the result is that at the time, I was 21, and drove a car that looked like it was straight out of Cheech and Chong, and the police stopped me all the time, and I had a felony in the trunk for years, felony possession. And, they took a look at me and figured I was a harmless, hopeless dope fiend and sent me on my way. And if I'd continued for 5 more years, I would have had a list of felonies. I would not have been able to become a licensed clinical social worker because you're not even allowed into graduate school with a felony. I would not be allowed to be a community mental health director because you're not allowed to be a community mental health director if you have a felony. All this stuff plays itself out. So I got clean and sober before the war on drugs. So it's given me some perspective. So with 40 years professionally in the field, I do have to say that right now is the worst drug crisis in this country's history since the Civil War. Okay, this is worse than the crack epidemic in the 80s. This is worse than the heroin epidemic of the 70s. This is worse than bathtub meth in the early aughts. Okay, in the last 3 months, we've lost more clients than we would normally lose in 10 years. Fentanyl in every single case. And I know because we have a Sentinel event debrief that I lead in the agency whenever we have a client death, and we do deep dives in these, okay, along with our medical director. Last 4 years I've been on the governor's maternal mortality and morbidity review committee, where we review every maternal death in the state. And the last 2 years they've tripled. Okay, fentanyl and violence is the drivers of those. Okay, so we're in a crisis, and I don't think we're really awake about the level of the crisis that we're having. And so there's a bunch of noise about Measure 110, and I know it wasn't designed for this, but if yep, great. But Measure 110 provides us locally with the kind of services that we absolutely need in order to address this crisis. So it wasn't intended to address the fentanyl crisis. But it's here, and it's exactly what we need. And the fentanyl crisis is driven, it's not about the state of Oregon, not about Measure 110. It's about Mexican cartels have figured out how to provide a very powerful opiate for very cheap. And they flooded the country with that. And when you do that, you're gonna have high addiction, and the dependency level that people are coming in is much higher than what we ever saw under heroin, and people die. And a lot of people die. And that's what's happening right now. We need to wake up and smell the coffee, as Landers would say. Yeah. So, what are we doing after that downer? What are we doing locally? Here are the organizations that are involved. And Best Care, if you want to treat severe opiate addiction, I've been in the field for a long time. These folks are coming in worse than we ever saw back in the day, with levels of dependency that are like, challenging all the doctors. You need to have medication-assisted treatment coupled with intense behavioral health services. That's bottom line, that's what has to happen. So here's organizations involved in our network, stood up. Here's how we framed these services, and this is really called a recovery management model. It was first outlined over 20 years ago. This should be nothing new, but hey, Oregon, this is new. You really are trying to create outreach and engagement, harm reduction. The great thing about harm reduction is you have lots and lots of opportunities to help engage people in recovery, okay? So, and then on-demand treatment access. So, eliminate the wait services. So the first, back in 1982, when I first became a drug and alcohol counselor, the first piece of wisdom I was given, very first piece of wisdom, I vividly remember this, is the supervisor said, strike when the iron is hot. Okay, that's bottom line with treatment, because we know motivation changes really quickly. So if you get that window, strike when the iron hot. What have we done traditionally in Oregon? Well, we'll put you on a wait list and we'll see you in 4 months. It's like, that doesn't work in addiction. People on the street know that doesn't work with addiction. So we've wiped out our wait lists. You can walk in and get treatment. You can walk in and see our doctors to get on medication, okay? And then we've developed a system of recovery supports. So we've developed, we're calling our burn center the Taylor Center, named after the first employee for Best Care, great guy, and we provide all these services there. And so a lot of this is harm reduction. We provide recovery housing. There's other recovery housing available in Deschutes, so we picked two niche pieces that no one else was covering, and that was we run a mother's outreach and mentoring program. So we've had for a number of years programs specifically aimed at reaching out to pregnant women who are shooting drugs. And you want to talk about stigma. Talk about a woman who's pregnant and shooting drugs. That's like, and they know it. But we have found that when we do outreach with women who used to be that woman, and we provide real services and start where they're at, we're able to engage half of them into recovery. And you think about the downstream savings of that, that is huge. we're saving hundreds of thousands of dollars, and we're delivering cute babies at the same time. It doesn't get any better than that.
Sober cute babies.
And then we've also established recovery housing for medication-supported recovery. Deschutes County Health Services has been a huge partner with us in Central Oregon, and here's the stuff that they're also doing. And then these are the early signs. So we only got funding in October. It takes a while to stand things up. I don't know if you've ever tried to do construction in Bend, Oregon. We still have permitting issues, just saying. So the burn center isn't fully stood up, but we do have mobile outreach. So still early going. One of the other things that has really, I think, is remarkable is, so we've been running this detox in Redmond since 1997. And a few years ago, I worked with Pacific Source, who's the main Medicaid funder, and we said, okay, maybe there's a way of increasing engagement from detox to outpatient services, because it stood at below 5%. So people go into detox, but nothing really happened. So we worked with them and got it up to like 35%, which is like best in the country. Now, with added supports, we're at 65%. I have to tell you, that's completely unheard of. It's crazy successful. Okay, just like, if I were younger, I'd like write it up for my PhD dissertation, but I don't care. So this is just some real, and so what's happening is, not only do we create a more compassionate set of services out there for people who are pretty much living on the edge, but we're also able to get a meaningful proportion of them beginning to flow into treatment. Okay, so that was the design, that was the purpose. Any questions about that? I wanted to leave time for Kristina, who would actually talk about what this looks like.
A question and I guess and a comment. I'm not familiar with drugs, but I'm a psychologist, so I'm concerned about motivation. And I think you hit it on the nail. Strike while the iron is hot. But your on demand means that the person. My implication was that the person is demanding. They're requesting to be served, and I know that some people may need a little extra push, somehow to be. So you've done something to increase the push to get people to accept the services, and I'm wondering what you do, or how would you describe that it's successful to get somebody. Now their concern may be, I just want to go back and get some drugs again because I want to deal with that, but you really want them to go a different way, and there's a big motivational issue right there. And
So here's the critical thing, in 40 years in the field, 42 years in recovery, I have to tell you, here's the bottom line. It's relationship that gets people into recovery.
Yeah.
Okay? And so, war on drugs, what that really did, we held their feet to the fire long enough that they could develop relationships with people in recovery that they wanted. Well, what we're doing now is starting out with the relationship first.
Yeah.
Avoid the whole criminal justice system and that expense, and get them engaged with relationship. And just to provide a sort of a personal experience, I remember I was relapsing a lot of times. I wasn't getting it. I was an angry young man. I remember walking into my first AA meeting and hearing people, really talk about recovery and still cussing like sailors. And it's like, I was home, right? And these people were speaking my language, and I knew I belonged, right? So And I remember as a counselor, you know, early experience as a counselor is, you know, doing family intervention. I had this young man, and everyone's doing the, you know, the classic, oh, here's all the things, you know, we don't do that anymore. The outcomes are bad. But this is what we were doing in the 80s. And the young man had his heels dug in. He wasn't going anywhere. 45 minutes of this sort of family torture, and it just wasn't working. And we took a break, and he went, this was a hospital-based treatment center when they still had smoking rooms in hospitals. And we took him back to the smoking room where our clients were in the treatment center, and I knew what they were doing in the smoking room. They were telling dirty stories, which is what they did. Great dirty stories. I won't repeat them here, but very funny. And he comes back and says, I need to check in. Right? That's what gets people in recovery.
Thank you.
Okay, and so Kristina's job has been for quite a few years, develop that relationship.
Hello. My name is Kristina VanAlstine, and I am also a person in long-term recovery from alcohol and drugs. I will celebrate 10 years next month. Thank you. I've worked with for Best Care Treatment Services as a recovery mentor and a peer support specialist for the last 7 years. And it is my heart and soul, and it is my passion. A couple of years ago, Rick Treleaven asked me and another employee, her name's Callie, if we would be willing to create an outreach program inside St. Charles Hospital. And at first I said no way, because I was just scared, you know, and but we ended up doing it, and it was the best 5 years of my career, because we got to go in and meet with patients at their very lowest and connect with them on a level that no doctor, nurse, or social worker could, because we have lived experience. We've been exactly where they're at. We've been in that hospital bed. We've been at our lowest. And we didn't have an agenda. We just wanted to share our experience and meet them where they're at and help provide whatever support they were willing to take. And it was a far cry from how I got clean and sober. And so it was a little bit of a learning curve. And I'll just tell you a couple of stories about a couple of patients that are successful now in their recovery. We got called down to the ICU, and this was when we first started. And there was a 19-year-old kid in diabetic ketoacidosis. He was addicted to meth, and he was not taking care of his diabetes. And he had been in the ICU 11 times in the past 6 months. And so me and Tally, we walk in and we're like, hey, how's it going? This is our name. This is what we do. How can we help? And he said, you can't. I said, okay. Well, can we at least reach out to you when you get out of here? He's like, yeah, fine. So he gets discharged. Comes back 4 days later, back to the ICU, diabetic ketoacidosis. And we walk up and we say, hey, hi again. You know, how's it going? Well, yeah, I'm back here. And I'm like, yeah, you know, it's a beautiful day outside. It really is not, it sucks that you're in the ICU, you know, and we start a conversation and we're telling parts of our story and really trying to connect with this young kid. And we find out a little bit more about him, and that he knows that he really needs treatment, but he has a dog. And he can't go to treatment with he doesn't have anybody to watch his dog. And so we leave that day, and we're just gonna reach out to him. We're just gonna keep trying to connect to him. And he gets discharged and he comes back. And I had built enough of a relationship with him to say, who's gonna take care of your dog if you're dead? And he said, get out of my hospital room. And I said, well, you know, I'll do that, but you know, I'm really worried about you. You're so young and you have such a bright future ahead of you. And he said, yeah. And I said, do you want to try treatment? And he said, if my dad will watch my dog, I'll go to treatment. And I said, okay, I'll take you there. And that Saturday he was discharged. I picked him up at the hospital. I took him to his house, helped him pack his clothes, and then I drove him to residential treatment and checked him in. He stayed the whole time. And then he went to sober living after that. He got his first job. He got his first relationship. And unfortunately, young kids and their relationships, things can kind of go south. And so he relapsed. He was back in the hospital that summer. And he didn't want to see us. But every time he was in the hospital, we walked up to his room and he stood at his door and, hey, he said, I'm not ready. And we walked off. Every time that he showed up at the hospital, he saw our faces. Until we walked past the door, stood in the door and said, hey. And he said, I'm ready. I said, all right, let's go. And again, took him from the hospital into residential treatment, supported him through that level of care, helped him get into sober living, helped him to get on the right medications, helped him connect with a primary care physician, and he's now almost 3 years clean. He has not been back to the hospital in that whole time, and he's living a fulfilled life. And so I guess that is what, you know, the peer part of Measure 110, why that is so important. And a lot of people talk about the harm reduction, and they don't see how that can help get people into recovery. And I didn't either. Until I started working in the hospital and realized that people who use IV drugs, most of them get infections, endocarditis, and they have to stay in the hospital for 6 weeks on IV antibiotics because they can't go out with a PICC line in them because, you know, it's too risky. And you know, they get wounds and hepatitis C and HIV. And I think what it comes down to is that these addicts can't find recovery if they're dead. And so the harm reduction aspect of it is kind of twofold in my brain. I'm able to connect with somebody who is still using drugs in a non-judgmental, supportive manner. And all I want is to get to know them and build that connection, and share my experience with the hope that they will someday find treatment and they'll live a fulfilling life. And then also to keep them alive long enough until they do have the motivation and the strength and the resources to get into treatment. And that's all I have.
How'd the dog do?
Dad took very good care of the dog. Yep.
Okay, great.
Yes.
I think that most of us know that Oregon has one of the highest rates of addiction in the United States and also one of the lowest rates of treatment. Can you tell us why and what Oregon in general is doing about that?
Yeah.
I'll let Rick.
Yeah. Ron may want to comment too. It has a long tradition of high substance use and low treatment. We also, frankly, have a beer and wine lobby that is very, very powerful. And they have worked very, very successfully to keep taxes on alcohol low, and traditionally keep funding for treatment quite low. And so that has improved since the CCO's reform came about, but it's been a struggle. And
CCO?
Oh, thank you. Some years ago, Oregon reorganized how it did Medicaid services into coordinated care organizations would create global healthcare budgets. And this sounds really wonky, and it is, but a global healthcare budget is a real great thing for substance use disorders, because before you have a global budget for healthcare, then treatment services is an expense that healthcare folks want to avoid. But once we're in the global budget, gee, I can dig down with the actuarialists at Pacific Source and prove that a huge portion of their expense is due to our people. And if I provide treatment, their expense plummets. And so now I get to debate treatment with healthcare economists who want to save money, instead of politicians who want to demonize my people I'm serving. That works really well. So we work that vein. But do you want to add about why but it's historical. It's been going on for
No, that's
generations.
absolutely right, it is historical, and the only thing I would add is that the funding system for our substance use disorder in Oregon it's been kind of in disarray for a really long time. One of the things I will point out about it is that what music?
Thank God that's not me. That's all I can say.
There's been this tension between substance use and mental health.
Yeah, this is making sense.
There's been this tension between where there was a while when they combined addiction and mental health into one department. And what happened was mental health received like 80% of the money, and substance use received like 20%. And so when they created then they stopped that and then created this behavioral health department, the behavioral health. And so behavioral health now does still kind of the same thing. As Rick was talking about the CCOs and how the CCOs, what pays for these services, there's Medicaid and then there's private insurance. And so for the coordinated care organizations, and I looked at the 2022 financial reports for all the coordinated care organizations in Oregon, and I was surprised that the line for substance use treatment was only $167 million for 2022. I was really surprised by that, because ballot measure 110 was 300. I said, how can we be twice what the CCOs are responsible for? And so there's a funding problem. I don't want to get too much in the weeds, but there's this capitation and fee-for-service and reimbursement rates that make it impossible for programs to continue to operate when they have increased costs and increased difficulty in treating folks who are on, because the drug supply has changed and the type of treatment and the type of client is changing. And so the reimbursement rates in terms of fee-for-service and capitation, those sorts of things, aren't making it possible for organizations to expand. They can barely even pencil out, so that would be fun.
I would say the caveat is our local coordinated care organization, which is Pacific Source, has actually been great to work with. I'd rather work with Pacific Source than any other CCO in the state. So, but yeah, we are responsible for 30 to 40% of the healthcare expense, And our piece of the pie, we don't actually get a slice of the pie, we get a knife and we get to lick it.
So I have, I'm a writer, and I have been contacted because, there has been an increase in, at our law enforcement dumping people while they're, you know, ODing at our, county jails. And so I'm wondering what your relationship with law enforcement is and how you coordinate with local law enforcement to address the needs of these clients.
Yeah, so Ideal Options, they have a recovery mentor embedded in the Deschutes County Jail. We have ongoing relationships with Deschutes County Parole and Probation, and Pfeiffer and Associates, which is another good treatment provider. They have been providing treatment services within the jail for 20 years. I competed with that contract and they won, and they still haven't given it. But they do a great job, and they're a good collaborator with us. So.
Yeah, that doesn't, I did a visit to the stabilization center.
And there's the stabilization center that Deschutes County has been running for the
And
last
law
few
enforcement
years.
can take people there, and they'll get, and there's peer support, and there's medical, services, there's, you know, so I would be really surprised. It's shocking to me to hear that with such an incredible resource, that stabilization center, which I believe is right next door to the
Yeah.
county jail.
So it is a challenge for law enforcement because if they come upon somebody, they're liable.
Right?
You can't just leave them on the street.
Right?
If they take them to the hospital, then they're off the street for hours. It's not a fast thing. And I don't know if you've been to the Bend Emergency Department in the last few years, but it's jammed. You know, go Friday night, and you see our people there. So that's a long wait. So I mean, they're under pressure to get out back on the street. How can they give this person to somebody before they die in the back of the patrol car?
Right.
You know, so
That's part of the problem.
yeah, I mean, I'm not blaming the police for that. I understand the pressures that they're under. So it's a systems issue.
So if you take them to the county jail, you've got medical services there.
Well,
And that's what's been happening.
yeah, and that's, you know, the problem in the system, and as community mental health director, it's, right now, the acute care system in mental health is in worse shape than I've ever seen it. And I literally grew up on the state hospital grounds. Dad was a shrink. I have long history in community mental health in this state, and it's like, oh my word, it's a complete disaster. The result is that the jails end up being mental health hospitals and are completely don't have the tools to do that, and it's a crisis in the jails. But it's not driven by the jails; they become a dumping ground.
This question's for Ron. Ron, you were mentioning that House Bill 755 had dealt with some modifications of Measure 110. I wondered if you could speak a bit more to what some of the modifications are?
So Senate Bill 755 was during the legislative session of 2021, and so it was the first. I'm sorry. So in 2021, during the long session, the legislature, particularly Senator Prozansky of the Lane County area, who's the chair of the Senate Judiciary Committee, convened a ballot measure 110 implementation committee. So he put together a work group that brought together folks from law enforcement, community corrections, behavioral health, mental health, folks from all over the spectrum in terms of being, criminal defense, expungement experts, and brought people together to really kind of go through ballot measure 110 and look at what are some areas that could be addressed. And some of the big picture items, just kind of to name a few, was the tribes were not mentioned in ballot measure 110. So the 755 created a tribal set aside for the 9 federally recognized tribes in Oregon. Youth were not mentioned in ballot measure 110. So it created it actually made it was added to the law that youth would be directed to juvenile court, not to adult court, and that they would be able to enter into an accountability agreement with that jurisdiction. Those are just two kind of big picture things. It's kind of slipping my mind what some of the other ones are. I could probably just grab my notes and kind of look through, but those are two of the big ones. But there was to create clarity, definition, and address the silences, and the two big silences were youth and the 9 federally recognized tribes. Yes.
Do any of the network of providers provide outreach to our houseless
Oh, yeah.
population, and how are you, if so, how are you connecting with that population?
So all of, let's see, Best Care Treatment Services, Deschutes County, Ideal Options, and I believe Rimrock Trails all have an outreach program. And our team right now, all they do is outreach because our building has been delayed. And so and so they do go out to all of the homeless camps, and they provide resources, they provide support, they provide basic needs, they provide harm reduction. So most of the people that we have got to engage with us are from the homeless camps.
And do you know the percentage of people that are that have drug and alcohol problems that are also homeless?
I don't know.
So I want to give a nuanced answer to that. So housing and drug use is interactive. So people like to give a directionality with that.
Yeah.
When I first started working in community mental health in Portland, my first job was reaching out into the state hospital and pulling people out and getting them set up, in East Multnomah County. And at that time, if you were on Medicaid disability, you could afford a simple 1-bedroom studio apartment. No way is that possible now, right? That studio apartment in Bend is 3 times what you're getting per month. And so if you're living on the margin and barely able to support that studio apartment, you're homeless now. You're out on the street. And guess what? Your mental health collapses when you're homeless. So you start with people who are marginal to begin with. You kick them out onto the street, they collapse. And what do you have to hold on to? And now, back when I got in the field, if you wanted to be a real hardcore drug addict, you had to come up with $200 to $500 a day. Now you're coming up with $2 to $5 a day. Okay? And you can be just as more severe drug addict than you could back when I started in 1980s money. So yeah, if you're in that situation, that's an easy way to cope with a pretty terrible situation, and you weren't starting with things working out well for you to begin with.
Yeah, I got really two questions. One is, doctors that give prescriptions for the population at large, how the dangers of using these drugs and abusing these drugs. To me, if you could prevent somebody from getting addicted in the first place, it ought to be cheaper than treating him after he's addicted.
Yeah.
Also, his lifestyle would be much better. To what
Right.
extent are we
Give
investing
you
in
a
education?
couple of answers. I've been on, locally, there's a pain standards task force. I've been on it for 10 years. And that's a lot of physicians, coordinated care organization, dentists, and I jumped in as a behavioral health person. And so, because when I came to this community in 1999, it was actually a fairly common prescribing practice for chronic pain for doctors to hand out a combo of methadone and Xanax. And I can't imagine a worse drug combo to try to ever get off of. And so we saw these really sort of crazy prescribing practices out there. And then what happened by 2010, there became an illicit prescription drug market happening here that didn't exist before. Central Oregon really didn't have an opiate problem out there that we were seeing at all before that. There wasn't heroin in the region at all. And then in the 2010s, heroin started coming in because you couldn't get your prescription drugs, you were strung out on them, and the drug cartels started supplying very cheap and potent black tar heroin. And so then by 2016, 2017, we started seeing a bunch of overdose deaths. And so we had to ramp up medication-supported recovery treatment services. And then really it's the last 2 years that fentanyl has totally replaced heroin. And at this point, it's crazy, we say heroin is harm reduction compared to fentanyl. And but you can't find heroin, so don't worry about it.
To what extent are we educating young people and others?
Yeah,
on
the state of
dangers so
Oregon
they
has
can
walked away from prevention services over the last 10 years. But I just was in a 3-hour-long Zoom meeting yesterday with the opioid settlement board, where we were going over, had the best expert in the state around prevention services, a researcher out of Eugene, and he was going over what would prevention services actually look like and should look like. So trying to figure out a strategy about how to rebuild that with those settlement dollars.
Media blitz.
Yeah.
I'm sorry to be asking all the questions, but it's an interesting topic for us. I'm gonna ask you about a PR problem that your program has, and that is that I'll call it the Lars Larsons, the Oregon Catalyst, the Jeff Eagers, the right wing, if you will, all depict your program as legalizing drugs in Oregon, which has caused every problem known to mankind, and they're getting lots and lots of airspace. And a lot of people, including a lot of the law enforcement people, believe that assessment. So in my opinion, that's kind of an enormous PR problem for you as well as a regular operational
Well, that's
problem.
Ron's problem.
So my question is, what's the program on your part to put in front of people the statistics that show that the program is working?
So the two things. One is that the Health Justice Recovery Alliance, as I said, has a media communications staff person, and her job is to kind of, when we see these articles and these interviews and that sort of information, we reach out to the, whatever that media outlet is, and to provide them with correct information, offer to provide people to provide testimony. We connect them with local providers and local advocates so that they can actually get better information and the correct information to challenge.
Anecdotally, do you have anyone who's been convinced?
I would say our work for the past few months has been primarily focused on the legislature. And so by being able to move the House from where it was a year ago to almost complete support of a bill for ballot measure 110 was huge. The second thing, so the Oregon Health Authority is responsible. They have like I know for me, I've struggled over years with tobacco cessation. And as you drive around, you see huge signs everywhere: stop smoking, quit now. Now, and I've wondered why, we don't have that for Measure 110. That you could just, there are that level of engagement. You can't go anywhere without seeing those signs. So the Oregon Health Authority has been saying that it's the Oversight and Accountability Council's responsibility to do this work, which is a group of volunteers who meet twice a month. And so the legislature in House Bill 2513, actually one of the changes that they made, or one of the amendments to Ballot Measure 110 and Senate Bill 755 in the Senate House Bill 2513, is now it allows the Oversight and Accountability Council to work with the Oregon Health Authority to develop a budget to do marketing and advertising and public education around Ballot Measure 110. So that's happening. Yes.
We're at 110 now. I just wanted to check in